We aren't using biologics like PRP or something like Wharton's jelly as a replacement for the good and evidence-based practice of medicine. It is a corollary. It supports the ethical, evidence-based practice of medicine. If you're thinking about, seeing a doctor and you have, knee pain and you've never seen a doctor before, please understand I'm not suggesting just jump in and have Wharton's jelly, applied to your knee. That's not what I'm saying at all. We're talking about when you've reached the end of your road, you've had your cortisone injections, maybe you've had hyaluronic acid injections, and you have a surgeon in front of you who says, you need surgery. We have to take in so many considerations to surgery. It used to be, we're never going to put off knee replacement because, earlier intervention leads to better outcomes. Well, now we know that with revision mortality, chances of dying from that revision mortality are high, or revision knee replacements are high.
Welcome to the Pure Wellness Podcast, where we talk about what it takes to live a holistic lifestyle by making conscious, healthier choices. Our hope is that these discussions will inspire you to strengthen your daily practice to improve overall physical, mental, emotional, and social well-being. Pure Wellness Podcast provides information solely for educational purposes and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. I'm your host, Johanna Altman, founder of One Body Medicine, avid health enthusiast, and mother of 3. Join me and industry professionals as we explore human potential in the pursuit of pure wellness. Welcome to Pure Wellness Podcast. Today I have very special guest, Dr. Scott Martin, who's a pioneer and leader in regenerative medicine and is also the head of the Outside of Advisory Board at Platinum Biologics. Dr. Martin has dedicated his career in advancing therapies like stem cell, PRP, and other biologics as safe, effective alternatives to surgery and long-term medications, offering patients new hope and alternatives to controlling pain management. In this episode, we'll dive deeper into his journey, the science behind biologics, and how these treatments are reshaping the future of pain management and healing. Let's dive into it. Hi, Dr. Martin. Thank you so much for joining me today.
Hi, doctor. How are you?
Good. I'm looking forward to our episode and diving deeper into the world of regenerative biologics. And I know you've been a pioneer in this field and have over 20 years experience in advanced biologic and non-narcotic treatment solutions for chronic pain and regenerative health solutions. So I want to start by asking you, what inspired you to pursue medicine and then eventually focus on regenerative medicine?
So I would love to say that I wanted to be a doctor my whole life, but I can't say that's the case. I come from a family of doctors. My great-grandfather was a doctor. My father's a doctor. My wife's a doctor. My twin brother's a doctor. I have uncles and aunts and cousins and nephews that are doctors. But when I was in school, I really wanted to be an architect. That's kind of where I had my passion. And my father probably very appropriately said, you know what, Scotty, because he called me Scotty, he said, you can do whatever you want to do after you finish medical school. And there are plenty of hospitals that need really good architects to design hospitals. So why don't you become a doctor and then you can design really great hospitals? And,
makes sense.
Yeah, it's smart of him. And so when I was finishing medical school, I had opportunity during fellowship to rotate at the VA at University of Michigan in Ann Arbor. And my residency director at the VA was Dr. Jack Rosenberg, who actually I just talked to a few weeks ago. Fabulous gentleman who just retired. And I had all of this wonderful exposure to cancer patients. And I'll never forget the day that I knew I didn't want to be a surgeon, but still wanted to be a doctor. I was finishing my training right before fellowship, and my father, who's a head and neck cancer surgeon, had me in on a series of cases. And my dad, who still practices, he's 84, still sees patients,
wow.
6.5 days a week. He had a cancer case, and he's associate professor of ENT at Washington University School of Medicine, and he was at the time teasing a tumor out of a patient's facial nerve and in the face, parotid gland tumor. The case was 7.5 hours, and I was just dying. My back was killing me. There was nowhere I could get comfortable. And I knew I didn't want to be a surgeon, but the esoteric nature of the case, just the fascinating science and nuance around that, and the fact that nobody else would do that surgery but my dad, anywhere in the Midwest, I figured if there's one patient out there like this that had to see my dad, I anticipate there are many patients out there looking for a doctor who's going to do something different, who isn't going to give them the usual and customary, and who might have an answer when there aren't good answers. And so that's kind of how I went into fellowship and how I've kind of treated my career.
Mm-hmm. I love that because it's usually that one special experience that that pulls us into our calling. And your dad was very intelligent to get you to finish med school, and then you could design hospitals. So
yeah, shrewd, intelligent, both. Yes.
Yeah. So having, moving forward from that experience and then finding your way into regenerative medicine. We hear the term stem cells and PRP thrown around a lot. And I get questions pertaining to these therapies all the time. In layman's terms, how would you explain each therapy, and who's a candidate? Who are candidates for these therapies?
It's such a great question. We have all of this wonderful optimism in medicine because so much money is being donated for cancer research and diabetes research and Parkinson's research. But at the same time, there's an equal amount of distrust, especially in light of, kind of what's happened with COVID. Yeah. And so There's misinformation on both parts. And so let's clear the air.
Let's do that.
From a very simple standpoint, our bodies have a wonderful capacity to regenerate themselves. Now, in order for our bodies to heal, to regenerate themselves at a cellular level, they have to have the right fuel to do that. Mm-hmm. Now, most people are aware, especially women. Not you, you're young, you look like you're 20, my goodness.
Because of all the therapies I do with you guys. Thank you.
As women get older, they become more prone to fracture, meaning their bones get a little bit softer. And almost everyone is aware of the fact that in order to keep your bones healthy, you need certain supplements. You need calcium, magnesium, and vitamin D. And you can take all the calcium in the world, but if you don't have some magnesium and vitamin D, your bones will still break. If you have, vitamin deficiencies, we know that, you can lose your balance if you don't have appropriate amounts of vitamin B12. These are supplements that aren't readily available in the common diet. Now, here's where it gets interesting. In our bodies, the majority of our soft tissue is made up of collagen. And not just one type of collagen, actually 3 types of collagen. And if we take something simple like our knee joint, there's actually 3 different types of collagen in the knee joint. Well, one type of collagen in particular is type 2 collagen. Now, our body doesn't make type 2 collagen, and it's not available in our common diet. It's not available in the Chick-fil-A, chicken sandwich you're going to have.
It's not on the menu.
It's not on the menu. It's not in your Starbucks, latte with 2 pumps of, caramel drizzle and, 3 shots of espresso, right?
Got it.
And because type 2 collagen in particular isn't made by our body, and it's not in our common diet, we lack it as a, quote, supplement. But that very cartilage makes up a significant portion of the intervertebral discs, the little cushions in between all the bones of our spine. It also makes up a significant portion of the cartilage in our joints, knee joints, shoulder joints, hip joints. Well, this is why we get degenerative disc disease. This is why we get degenerative joint disease.
I see.
Because something so important our bodies don't make, and it's not available in our diet. And so we have evolved in medicine from cortisone injections and things like that to refining our own blood for the very growth factors in it to encourage the body to generate this very same type of collagen. Now, there are growth factor complexes within our body that contain collagen, and those sources can come from our blood, from our bone, and from our fat. You can also get those growth factor complexes that help encourage the body to generate collagen at a cellular level from sources outside the body.
Exogenously.
And the most common source, right? The most common source is from the umbilical cord that attaches mom to baby. Now, we're not talking about baby parts. We're not talking about fetal tissue. We're talking about afterbirth that would otherwise just be thrown out, because 90% of the umbilical cords and the placentas from birthing mothers are just thrown in the trash and incinerated.
And Doctor, sorry to interrupt you, but I think that's an important part, because people need to understand, in some of the questions I get are there cells in this umbilical cord, right? Will my body accept the stem cells in this umbilical cord and whatever it is that are the cells that are being derived? So just want to mention that.
So, wonderful point of clarification. So if I take blood from my own arm and I spin it down and I put it back into my body, no harm, no foul, right? I'm using my own blood, spinning it down, putting it back in my own body. I'm not going to get something called a graft versus host response, meaning that blood product is my own. It's got little markers on it that make it mine. Those are called antigens and RH factors. Now, those antigens and RH factors are in all tissues. However, in the umbilical cord itself, that tissue, something called Wharton's jelly, which if you take an umbilical cord, which is 28 centimeters long, not very big, and you open it up and you take the 3 vessels that are out, the jelly that's inside that, which doesn't look much different than Jell-O jelly, that is something called immune privileged tissue, meaning it doesn't have all of those antigens on it that would otherwise make it harmful to apply to the body. So we don't get kind of that, quote, graft versus host response. But if, like, you were just super nice and I was bleeding on the side of the road and you were like, well, I'm going to give you a blood transfusion, unless our blood types are exactly the same, even though you're trying to save my life, you may actually make me worse, because your blood type has to be matched to mine. And this is why, when you're giving blood and you go to like the American Red Cross, they ask you what your blood type is. And if you don't know, they type your blood to make sure that when you donate blood and a recipient at a hospital or a trauma, gets that blood, that it's the same blood type. So umbilical cord tissue, umbilical cord cells, umbilical cord derived mesenchymal stem cells, those are all immune privileged tissues. So they're not going to cause a cross reactivity with the human body.
With regards to stem cell therapy and PRP, what type of conditions are you able to treat with? I know, pain, usually there are applications for stem cells and PRP where you can use them for points of pain in joints, knees, shoulders, spine, things like that. What therapy do you prefer? And is, PRP or stem cell? And, is everybody a candidate for stem cells?
So first, let me make it just a subtle distinction. In general, when we're talking about stem cells in the United States, we're talking about differentiated mesenchymal stem cells. We are not talking about pluripotent stem cells. Pluripotent stem cells come from fetal tissue, from aborted fetuses. That's been illegal in the United States since George W. Bush was president. Now, there was some early experiments with pluripotent stem cells, and you may remember that we cloned a sheep. That sheep's name was Dolly. Now, Dolly was created using pluripotent stem cells. Unfortunately, Dolly passed away from cancer at the age of 5. Now, that was bad, but what was worse was that Dolly had 5 baby sheep, and all 5 of Dolly's baby sheep died of metastatic cancer within a year of life. And so this is one of the reasons we don't use pluripotent stem cells in the United States, because they can become anything in the human body, including cancer. Now, unlike you look 20, I'm 52 years old. I'm unfortunately closer to the finish line than I am to the beginning. And so do my cells have the propensity to be turned on and become cancer-forming cells? They do, right? And because I'm older, there's a greater risk of that. So would I use a, quote, pluripotent stem cell with that type of risk? I never would. And they're not available in the United States anyway, and if they are, they're very illegal. So we're talking about differentiated mesenchymal stem cells. Now, my favorite application, and I think where society benefits the most, is actually just simple degenerative cartilage in the knee. Most people don't appreciate that the cartilage-based issue in the knee, osteoarthritis, traumatic arthritis, inflammatory arthritis, number one, is a $5 billion marketplace every year for just problems with the knee. Mm-hmm. That's number one.
Crazy.
Number two, over 35 million Americans suffer with terrible knee arthritis that drives them to the doctor on an annual basis. There are over 1.5 million knee replacements in the U.S. every year. And so when we as a society look at kind of the greater good, and as a provider, we're always worried about the greater good. How do we make an impact in somebody's quality of life? Well, if you have terrible arthritis in your knee, you can't go to work. You can't play pickleball. You can't bend down to pick your grandchild up. You can't pick the dog up. I mean, there's all sorts of, you can't get the laundry off the floor. Very practical things are impacted by something as seemingly simple as degenerative cartilage in the knee. And so there are very good randomized controlled trials looking at the application of platelet-rich plasma, PRP, for the knee. The problem with those really robust trials is that there's no standard for how to do that procedure. And because there's no standard, meaning every doctor prepares PRP a little bit different, mm-hmm. it's hard to get a consistent outcome. And so what I mean by that is, for the standard patient listening to this, if you were to see a doctor in Southern California, and then you were to see another doctor in the same week in Seattle, and then maybe get a third opinion in Tampa, Florida, all three of those doctors would most likely prepare the very same blood product from your arm in a very different way, and they would get very different outcomes. And that's a problem, right? Because there's no universal standardization for that procedure. We don't have randomized controlled trials for the use of umbilical cord-derived tissue, umbilical cord-derived differentiated mesenchymal stem cell growth factors, Wharton's jelly. That's actually a personal project of mine, really a passion project. Probably be one of the more defining things of my life, where I am working towards doing the first randomized controlled trial ever done in the world comparing PRP with the application of something like Wharton's jelly for degenerative joint disease of the knee. And we'll be starting that next year. Because this is such a huge problem, and because there's no central standardization for PRP, but there are standard preparations of Wharton's jelly. Mm-hmm. The question is, which works better?
Yeah, that's actually very interesting. I've not thought about, that issue, which is a major issue in terms of being able to do clinical trials, because there is no standard on how the PRP is derived. So how are we able to get consistent data right across the board? It's very interesting. Doctor, what would you say to a patient who might have seen a specialist and is now coming to you and saying, Dr. Martin, I've now been told that I need to have, knee surgery. I'm in my 30s. I see this all the time in our clinic, or I'm in my 40s. I mean, these are young patients coming in. Maybe they were athletes that have kind of just like, the cartilage between the knees, they're runners or whatever. And now they're just bone on bone. What would your recommendation be? Would it be obviously to try one of these biologics, therapies first, give it time? And if so, how much time would you say is realistic to see if the body is responding well to this therapy before going to the ultimate decision of having a surgery? Because that to me is really the ultimate last, decision.
So I think it's critically important to point out two things. First and foremost, when we talk about biologics, and I know you do this in your clinic just like I do in mine, we aren't using biologics like PRP or something like Wharton's jelly as a replacement for the good and evidence-based practice of medicine. Mm-hmm. It is a corollary. Mm-hmm. It supports the ethical, evidence-based practice of medicine. That's critically important. So if you're thinking about, seeing a doctor and you have, knee pain and you've never seen a doctor before, please understand I'm not suggesting just jump in and have Wharton's jelly, applied to your knee. That's not what I'm saying at all. Physical therapy, over-the-counter medications, chiropractic manipulation, acupuncture, mindfulness, meditation. There's literature for all of this. We're talking about when you've reached the end of your road, you've had your cortisone injections, maybe you've had hyaluronic acid injections, and you have a surgeon in front of you who says, you need surgery. Mm-hmm. And you're 30, or you're 40 or 50. We have to take in so many considerations to surgery. Number one, and this is critically important, we have much newer technology with regard to joint replacement, just from the structures we're using for joint replacement. However, our patients are now more sick. 30-35% of the population is diabetic or pre-diabetic. They don't heal quite as well. We're all post-COVID. Our immune systems are much more challenged, having to fight off that virus and achieve kind of herd immunity. Mm-hmm. So all of us are just a little bit immunocompromised. And so it isn't the case that if I have a knee replacement that it's going to last me 20, 30 years. Mm-hmm. Because there is mortality. There is predictable risk of increased mortality with revision knee replacement. It used to be, well, we're never going to put off knee replacement because, earlier intervention leads to better outcomes. Well, now we know that with revision mortality, chances of dying from that revision mortality are high, or revision knee replacements are high.
Doctor, so for patients that are, do you have the statistics for patients that are getting, these knee replacement surgeries? What percentage of those patients have to do revision or having to redo that surgery later on?
It is very operator dependent, but you can have adverse events up to 13%.
Oh, wow.
Now, these are outliers, right? Standard adverse event ratio in patients for knee replacement are somewhere around 4 to 5%, right? But you do have some outlying case reports, some outlying systemic reviews where you can have very, very high adverse event ratios. It does tend to be operator dependent. It does tend to be more common with more aggressive and more end-stage joint disease. Your grade 4 arthritis, bone on bone, right? In a patient that's suffering terribly from pain and they've been suffering for a while, their outcomes are poor because we go into surgery the way we come out.
That's right.
Think about it like this. If you go into dinner, a date with your spouse, and you're in a terrible mood, right? And maybe you almost got in a car accident on the way there because you were late for your reservation. Probably not going to have a great dinner, right? Well, if you go in very sick, in tremendous pain, very frail, very stressed to something like a knee replacement, your outcomes are going to be poorer. And so to bring this full circle, you can always have surgery. It's always on the table. But if you have an adverse event or a very bad complication after the surgery, that cannot be undone. The worst potential complication from an allograft application, whether that's PRP or something like, Wharton's jelly, is that it doesn't work as well as you wished or hoped. And you end up having that joint replacement anyway, or that surgery anyway. But if you do have a joint replacement, you get a bunch of scar tissue, right? That terrible scar tissue means that your physical therapy is harder and much more complicated. And then during physical therapy, they get a bit aggressive, they get a bit spicy, right? And they rupture your ACL, which just happened to a colleague's wife. Now we have somebody who had surgery for a meniscus tear, developed a ton of scar tissue postoperatively. We're told they had to have surgery, no choice. In postoperative therapy, there was so much scar tissue, they decided to get a bit more aggressive, and they ruptured completely her ACL and tore her PCL as well. So now she has to have revision surgery because they completely ruptured her ACL, and she'd have an extremely unstable knee otherwise. Those issues are finite. There's no turning back the clock. And so what I would say is everyone a candidate? Well, no, not everyone's a candidate. If you've got active cancer, you're breastfeeding, or, you're pregnant, I wouldn't suggest allograft applications, right? Not that we have literature that states specifically that there are complications, but why poke the bear, right? If you're breastfeeding or you're pregnant, let's focus on that, right? If you have active cancer, let's please focus on that, right? We'll address the knee issues later.
Doc, I wanted to find out what your thoughts were on how regenerative medicine fits into the bigger picture of healthcare today. Do you feel, you've been in this a lot longer than most doctors. You're a pioneer in this industry. Do you feel we're at the beginning of a shift? Are people catching on to these types of therapies? I feel from my experience, I'm seeing more patients becoming advocates for themselves. And I just wanted to know what your thoughts were on that.
So, and I'm going to button my coat for this because it's going to be a little spicy here.
Okay. Let's do it.
In a market just like knee, where you have $5 billion at stake, there are a lot of people that stand to lose a lot of money if something works better than drugs, than surgical intervention, and other things. And when there's a lot of money at risk, right, there's a lot of regulation and there's a lot of other things. But ultimately, it's patients that will decide their own health care. I did my third-year medical training in the Royal College Hospitals in London, in particular Kingston upon Thames Hospital, gorgeous hospital. There they had a two-party system. They had national health care, which was available for everybody, and then they had a cash-based system where maybe you didn't want to wait for a year and a half to get an MRI. Maybe you didn't want to wait for a year and a half to get a stent because you just had a heart attack. Well, you could pay and you could get care much faster. Mm-hmm. Well, patients are now becoming much more aware that if they want better care, it's at the end of a credit card or the end of a dollar bill. And if their insurance doesn't pay it, if their health plan doesn't pay for it, if their doctor doesn't do it, just like aesthetics, if I want Botox, my insurance isn't going to pay for that, or maybe I want a facial, or I want, hair restoration, whatever it is. Insurance doesn't pay for that. And if I want that, I'm going to go out and get that. Well, patients are choosing to lean into their care with their own money. And this is forcing a change in our regulatory environment. We've just seen very large stem cell bills passed in the state of Utah and passed in the state of Florida.
Mm-hmm. That's amazing.
Next year, I anticipate more states passing state-specific stem cell bills, very much the way that marijuana was passed, right? We had this groundswell of patients, not doctors, patients that wanted access to CBD, medical marijuana, and because patients moved the needle, states passed laws accordingly. This very same groundswell is starting to happen with biologics, where patients are saying, hey, look, we're smart enough, and we're seeing that our friends, relatives, somebody next to me at Starbucks, somebody waiting with me for 4 hours at the DMV, are saying that they got really significant clinical outcomes with biologics, whether that's PRP or umbilical cord-derived products. And they're making decisions with their pocketbook, and because more and more of them are, it's forcing state-level changes that comply with patient desires. And I love this.
I love that you're explaining it from that approach, because you're right. You're correct. By the need and the demand going in that way, even though we are a cash-based industry right now, regenerative medicine is not being recognized by insurance companies as a real form of therapy or, treatment. It's forcing healthcare to kind of move in that direction. And it makes me feel more empowered, to be honest, because I never really looked at it in that way.
So two things are going to happen. Insurance is a business just like selling hamburgers and chicken sandwiches. And when insurance companies start to see patients exercise their freedom with their pocketbook and move further away from insurance covered products like drugs and cortisone and things and surgery, right? They will have to follow suit. They'll have to.
I agree. I
now,
like that.
There are a couple really large pharmacy benefit managers, meaning the companies that manage the drugs that your health plan covers. And I know personally of a regenerative medicine pharmacy benefit manager that's looking to be one of the first. There's a billionaire very quietly now doing very significant investigative work to see if a regenerative pharmacy benefit manager might be a wonderful cash-based opportunity as a supplement to traditional insurance, so that if patients wanted a supplemental insurance policy for regenerative therapeutics, that would be something that they could buy in the commercial marketplace. And I think that's genius.
That's genius, because now we're integrating traditional medicine and the original healthcare system with the new wave of therapies, and we're combining them and not just saying we're going to stick with one or the other. I think that's genius.
Well, now it's patient choice, right?
That's right.
If you can DoorDash a milkshake just like you can DoorDash a salad, right? And that's your choice. Well, I mean, we've always been about freedom of choice in the United States, always, with everything, right? Men's health, women's health, and everything else, right? So why shouldn't a billionaire, and hopefully he watches this and it encourages him to move forward because he's on the fence, to provide an alternative? Because if they do, it won't be the first.
Yes, and I think that will really open the door of opportunity to all of these other therapies. That would legitimately open the door to this side of medicine, and I think would be a way to integrate into the current healthcare system.
Well, I think that's one door that we need opened. I think that there's a regulatory door that could be opened as well, right?
Yeah.
Right now, if you wanted to use an umbilical cord derived product, from a federal standpoint, you have to have something called an investigational new drug paradigm just to do a comparative study, right? From an evidence-based standpoint, we make all clinical decisions, the majority of our clinical decisions, based on peer-reviewed evidence. The randomized controlled trial, it's literally considered the gold standard for how and why we do things, right? But there's a bit of a regulatory hurdle to use umbilical cord derived products because they don't carry the same exemption that autologous blood, bone, fat products have to do something like a randomized controlled trial. With this groundswell from patients, with potentially a groundswell by a pharmacy benefit manager, whereby patients are now requesting more access to this, I think and I hope that regulations will soften. Not to say, hey, look, Medicare is going to pay for PRP and Wharton's jelly applications and we should expect that. But that maybe regulations should be softened so that we can actually get to the root of what's best. Look, I mean, it wasn't that long ago. I mean, well, it was, I was a kid, we used to do the Coke Pepsi challenge, right? Which is better, Coke or Pepsi, right? All of us, probably remember, Bud Light, taste great, less filling, these kind of challenges. Well, in medicine, we need that comparative analysis, not for us as doctors, right? Patients need it because patients should have choice. They should have a comparative analysis, whether drug A is better than drug B, and that trial should be done, right? Biologics is new and it's evolving and it's rapidly growing. And certainly I think that the FDA is 100% everyone's friend. And I say this in many of my lectures. The FDA is your friend, right? The FDA is kind of like in a bowling alley. And they're watching patients and they're watching doctors and they're putting up those little things in the gutter so nobody gets a gutter ball, right? So nobody has a terribly adverse event, all right? And I think that's a good thing. I think it's a wonderful thing. But I do think that maybe the FDA should allow people with size 5 shoes and maybe size 12 or 15 shoes to be able to bowl as well, right? And maybe add a few more bowling balls to the mix to see which gets a better strike, the 6-pound ball or the 15-pound ball, right? And I don't know that that's going to happen tomorrow, but I think the more and more patients get anecdotal evidence that these things work, that patient-reported outcomes don't become anecdotal, they become the norm. And the conversation moves from we're going to cure you, which I think is dangerous, to let's support the evidence-based practice of medicine as a last resort prior to something definitive like surgery, or even prior to like changing you from a prescription medication that you're on that's working very well to something you've never taken that may have more side effects. And prevent dose escalation, prevent changes in medications, prevent the need for intervention, and support common evidence-based practice of medicine was something that may just be wonderfully significant with regard to improving a patient's function as well as quality of life.
Well, I love that outlook. I love the outlook and the optimism of feeling that, patients might and will have more choice and option later on, because right now it feels like we don't have as many options. So I like the optimism in that. And doctor, thank you so much for your insight and your perspectives and points of views, and for clarifying, biologics, stem cells, PRP, and how everything kind of works in a very basic way. It was such a pleasure speaking with you today.
It's my humble pleasure. Thank you very kindly.
Thank you so much.
Have a very blessed day.
You too. This podcast is sponsored and brought to you by One Body Medicine. You can learn more by visiting onebodymedicine.com. That's the number 1, bodymedicine.com. You can also follow the show on social media under the handle Pure Wellness Pod. Thank you for listening, and we'll see you next time.